Good morning, everybody. My name is Anila, and I'd like to talk to you today about sleep deprivation and its effects on bone metabolism. And I want to take a quick second to say thank you to the EFF for inviting us to New York to come work with you and learn from you. And actually, New York is the right place. New York City is actually really the right place for this topic because many people do say that this is a city that never sleeps. And so they really should be aware that maybe bone issues are something that they should be concerned about. So what are the functions of sleep? Now, we all know what sleep is, and so I'm not going to go through what actually sleep is. However, if you ever have a chance, you should just Google what the definition of sleep is because it's really poetic. So I'm just going to read one of these to you, but it's a condition of body and mind in which the nervous system is relatively inactive, the eyes closed, the postural muscles relaxed, and consciousness practically suspended. Just sounds so beautiful. I really like it a lot. And then the functions of sleep, we all know what that is as well, but I'm really going to focus more on restoration because that's kind of where I think that bone metabolism potentially falls in. But as you know, there's a lot of different functions of sleep potentially. So the CDC calls sleep deprivation an unmet public health problem. They also call it an endemic. And what they mean by this, by sleep deprivation, is somebody who's getting less than 7 hours of sleep per day. So it's more than 1/3 of Americans that are not getting sleep on a regular basis. And actually, if you look at this chart here, they're comparing men and women between 1985 and 2004, and you'll see that the incidence really has gone up quite a bit. And this is only 2004, and since then it's actually increased even more. So it's really interesting because sleep deprivation really is a problem that we tend to ignore very often here. We all know that sleep deprivation has a lot of negative metabolic effects. Of course, weight gain, we know in shift workers. We also know it's an increased risk of glucose intolerance. So what I was curious to know about is, does sleep deprivation also affect bone metabolism? So I looked through a little bit on the literature, and interestingly, there really isn't very good literature on this yet. One of the ones I did find that was really interesting was bone mass accrual in children. So they looked at 336 children aged 4 to 12 years old. They looked at their bone mineral content measured by DEXA. This was found to be greater in children with longer sleep duration, as well as napping, which was actually associated with the higher bone mineral content. I hope they replicate this in adults because I do think that we could all probably benefit from napping as well. And they found that sleep duration of less than or equal to 8 hours may impair bone mass accrual, especially during periods of rapid growth. And this is really interesting because this isn't really something we've ever seen, or I don't think we've ever really talked about this during our course, and I'm not really sure that it's something that's recognized, likely because there needs to be a lot more data on it. But it would be interesting to know if your peak bone mass is inhibited if you're not really getting the proper amount of sleep. Now, there were a number of other studies that did look at adults as well, and I'll talk a little bit more about why. I don't know how reliable those are, but the first one I want to talk about is with 600 Chinese women. Women with lower sleep duration tended to be older, and they had a lower total and regional bone mineral density, which was statistically significant. However, they never actually tried to figure out, if you take away the age aspect of it, if you control for that, whether that was still true. So I wasn't sure that this study was something that we could really rest too much, of our assumptions on. Another study looked at 2,600 Korean subjects over the age of 60. This was really interesting because they actually found an inverse dose-dependent association between sleep duration and bone mineral density. So what they were actually suggesting is that if you actually have more sleep duration, that your bone mineral density is actually lower. So maybe this could go along with if you're obese or something of that sort, but this was one of the only studies I saw that actually suggested this. And then there was another one that looked at about 5,300 subjects, and they found that shorter sleep duration, less than 6 hours, was significantly associated with osteoporosis, but only even after you adjusted for other variables. However, this was only true for the people that were above the age of 65. Now, these are mixed results. There are a number of other small studies that suggest something similar, but it's mixed results. And one of the things that's really difficult for these studies is that it's mostly self-reported data. Usually when they talk about sleep duration, they ask people how many hours are you sleeping at night, and that's what they're going by. In fact, this very last study, the way they identified whether or not they had osteoporosis is they would say, did your doctor ever tell you had osteoporosis? And if you said yes, then they counted that as you probably have osteoporosis. This one was actually a little bit more interesting to me and maybe a little bit better done as well. This was looking at sleep apnea and bone resorption, and they took 50 men who were going to be visiting a sleep clinic for sleep apnea. 29 of them had moderate to severe sleep apnea, and then they had 15 age-matched controls. The apnea-hypopnea index was positively correlated with urinary CTX. So essentially, if they had worsening sleep apnea, they actually had higher levels of urinary CTX as well. And interestingly, there were no correlations between any of these other markers. And then what they did is they actually took those 29 subjects with moderate to severe sleep apnea and started them on CPAP for 3 months. And what they found was after those 3 months of treatment, their urinary CTX actually did come down quite a bit, and it was statistically significant. So this suggests that possibly moderate to severe sleep apnea is associated with higher bone resorption, but that maybe this effect is actually reversible if you start on treatment. So then we went ahead and did our own study here at University of Chicago, and some of the things that were a little bit different in this study was one of them, and I'll kind of go through the study with you a little bit, but one of them was that we actually did observe people while they were sleeping, and we have an idea of exactly how many hours they actually were sleeping, so that was a little bit different. We also looked at acute sleep deprivation rather than chronic sleep deprivation, and then the third one was because of that, we actually looked at bone turnover markers. The study that I just mentioned was one of the few that actually does look at bone turnover markers instead of bone mineral density, so this was something that I thought was interesting and a little bit different. But we had 13 subjects. These subjects were actually previously, they were subject in an alternative study, and they had some serum left over, and after getting permission, we did go ahead and use that serum, so it wasn't necessarily, we didn't recruit them initially right off the bat, but as you can see, there were 3 females. There were a mix of races, but predominantly Caucasian. The ages were mostly between 20 to 30. Most people were either normal weight or normal BMI, I should say, or they were a little bit overweight, but nobody was obese, and their calcium and creatinine seemed to be okay. The protocol we were using is that the labs would be drawn at baseline from an oral glucose tolerance test that was drawn when they initially came in for their screen, and that was done about 1 month before the actual intervention period. And then we actually use a randomized crossover design, which I'll talk about in a second, but they would be basically, the protocol would be they'd be in the lab for about 5 nights, and they would be there twice. And the 2 different variables, they would be separated by at least 1 month, so there'd be that washout period. Each session would have that very first night was a habituation night, and then the 4 experimental nights. So either they would be in the lab for 4 nights and they would only be in bed for about 4.5 hours, or they would be in bed for about 8.5 hours. And what I mean by the randomized crossover is some people initially had the short sleep, and then 1 month later they came in for the long sleep, whereas some people had the long sleep and then 1 month later came in for the short sleep. And then the morning after that 4th experimental night, they had an IV glucose tolerance test, and that's when the labs were collected. And they did try and keep everything else pretty relatively the same. And this is that same information in a little bit more of a complex diagram. So you'll see the normal sleep is that long sleep I was talking about. This first night for both of these is the habituation night. We didn't really count that and are not looking at that necessarily for analysis. But then you have 4 nights of experimental long sleep, which is 8.5 hours. And then you have an IV glucose tolerance test, and these are 4 hours of short sleep, and then you have an IV glucose tolerance test. And we elected, like I said, to look at bone turnover markers. So the bone formation markers we looked at were P1NP and osteocalcin. The bone resorption markers we looked at were CTX, and then we also looked at PTH. And of course, we assumed that most likely we would expect to see higher bone formation markers in the long sleep and expected to see lower bone markers in the, bone resorption markers in the long sleep. And now this is very preliminary data, so we have quite a bit of analysis to still do, and we still have to look at this quite a bit in detail. But our findings have actually been very interesting. So the parathyroid hormone was essentially about the same. There wasn't a significant change. But the P1NP, which you'll remember we expected to see higher in the long sleep, was actually a lot lower in the long sleep when you compare it to the short sleep. This wasn't necessarily statistically significant, but it is interesting, especially because osteocalcin, which again we expected to be higher in the long sleep, was also lower in the long sleep. And then CTX actually seemed to follow with that as well, where we would expect that one to actually be lower in the long sleep, but it's actually higher. So it's really interesting because we don't quite yet know how to explain this. We did look a little bit at the different charts to get a sense of if there's anything that explains it. And one of the things that we did notice so far is that there does seem to be these outliers, and the subjects 47, 49, and 74. And the other interesting thing about that, when you look at the P1NP, it's the same people. So what we're trying to look at now is to see if maybe these 3 subjects, maybe there's something different about them than there is about everybody else. I know Dr. Bilazikian has said that we should find these rare diseases, and that's where you learn the most, and that's actually what we're curious about here, is maybe we can find out a little bit more about why we found these unusual results by looking at these 3 particular subjects. So that's still pending, but some of the analyses that we're doing, so we actually do have actigraphy data. Every single one of the subjects that were in the lab, we actually know exactly what time they went to bed, how much activity they had while they were in bed, as well as when they were awake. So we're in the process of trying to analyze that right now. Possibly posture could be affecting this. As we know, that can affect the various bone markers, so that's something that we're going to be looking at as well. We do have, luckily, quite a bit of other hormonal variables that we do have data on as well. So we'd like to take a look at the growth hormone levels, the ghrelin levels, the leptin levels, and see if there might be some differences there. And then anything else that maybe you guys can contribute to, or maybe any other thoughts you have, I'd really love to hear those to see if that might be able to help us as well. And then these are Dr. Tamara Vokes, Dr. Van Cotter, and Dr. Hanlon were the three people that really helped us out with this study, and I've been working with them closely for this, so I just wanted to thank them as well.